This is a female, 23 years old. She's studying in university, and she has no general health issues. Bilateral cholesteatoma. She had left ear cholesteatoma surgery 6 years ago, and she had a dead ear in that surgery. A right ear cholesteatoma surgery 3 years ago, and no reconstruction done during that moment, and a conductive hearing loss with a normal bone conduction threshold in her only ear. She comes to our clinic, and she has been offered a hearing aid that she can't use due to recurrent infections. So she absolutely needs one, but she can't use it, or every time she uses it, she has discharge in that ear. She has to stop using it. If she stops, she doesn't have a good hearing. So she might ask for a reconstruction surgery in that ear. The ear doesn't look bad when it's dry, or there might be another solution. I don't know if I should continue with what we did in that case.
Why don't we do the poll first,
absolutely.
and then before you give away the answer of what you did there, and then you can fill us in.
Okay, so there is quite an awareness in our audience, isn't there? And yes, we didn't consider to go for a reconstructive surgery because it was her only hearing ear. And we know that in chronic otitis media, there is a high chance of suboptimal benefit from these reconstructions. Being her only ear, we didn't consider that. She tried a hearing aid, it didn't work, so we went for a bone conduction implant, in her case, a percutaneous Baja 5 implant and some processor.
So if she had had serviceable hearing remaining in the left ear, would that have changed your approach?
Being that she had only been, or she only had surgery once in that year, it depended in how that middle ear was during dry moments, if the tube might be functioning, if she was willing to have serviceable hearing without any sound processor. This case, being 23 years old, only one surgery in that year, it might be a case for trying once again.
Any of the other panelists want to talk about that? So a 23-year-old, if she had serviceable hearing in the left ear, would you have gone in for a second look in an OCR, or gone right to bone conduction? Dr. Thakkar, good morning.
Morning, evening rather. Hi.
Evening.
So, yeah, I mean, looking at this patient, there's no doubt that she needs good hearing rehabilitation, looking at her age and her ambition. And yes, everybody needs good hearing rehab. And this girl, the best solution undoubtedly seems to be a bone conduction or a bone anchored hearing aid there. My only small concern would be that a hearing aid has not been successful, and that's not too much of a surprise, but just to check what kind of a hearing aid she's been using, because I mean, if she's using a behind the ear hearing aid with an open fitting, then of course that is much less likely to give problems than a in the ear hearing aid, which tends to obstruct the ear canal. So just to see as to what kind of hearing aid she's using.
She has tried several, and she has tried also a BTE with a good ventilated fitting in the external ear canal too. But she continues having, or she continued having these discharges during that period of time. Now that she's wearing a bone conduction implant, she has discharge sometimes, but much less than what she used to have before.
And in any case, a discharge does not interfere with her hearing. So even if she has a ear discharge, she continues her hearing.
No interference with her hearing at all.
Undoubtedly the best solution, yes. But
Would anyone,
we don't
sorry.
end up using this solution primarily for the economics, and that's been talked about already.
Mhm.
Would anyone consider a bilateral implantation?
Yeah, I was raising my hand already, Brian, because I was already, of course, very happy to see the awareness for a unilateral bone conduction device, but indeed, it might be even more beneficial to have the cross-hearing effect as well, by putting also bone conduction device on the left ear. And this might be something that you stage. You first, of course, rehabilitate the right ear and then try what is the benefit of the left ear additionally. Of course, if there were no recurrent infections, then also conventional cross device would be beneficial in addition to a unilateral bone conduction device, is my experience. But bilateral, I have seen very happy patients with this indication and bilateral application. So I did also wanted to make awareness for that part. And well, that's it for this moment.
Thank you.
So Brian, let's be provocative. I mean, if you do an MRI scan, a T2 MRI scan of the temporal bones, and you see that the cochlear duct is open on the left side, why wouldn't you consider a cochlear implant in that ear? Single-sided cochlear implant and a Baha on the other side.
You absolutely could. And I think we're going to talk about obliteration at one of the other cases coming up, and then where that fits into your algorithm. Anyone want to comment on, would you consider a left-sided CI with this case?
I have the same question that Douglas. I will perform a Baha solution in the right ear, but I will think about the cochlear implant in the left ear.
Yep, I agree. So would I. Anyone else want to talk about that or how they might approach that?
I just wanted to check if there was if these were open cavities requiring any further follow-up for cholesteatoma, and if there was an MRI requirement. If there were open cavities, which you can look into, I'm just seeing there's a slight dip in higher frequencies coming up. And if there was serviceable hearing on the other side with a similar high frequency dip coming up and probably progress with the young person, I might go for a transcutaneous osseous, which I think later on Professor Lenhazer's cases show the huge gain on that. But I would now try and move away from percutaneous if you can, especially in cavities which you can examine without scanning.
So this case were open cavities obliterated primarily. So MRI was the follow-up main option. That's why a percutaneous system was used in her right ear. It's only 3 years or 2 years when she was implanted since surgery. So there was still some MRIs planned in this case.
It's a female, 65 years, works in a factory as operator. She's married and has 2 children. The right ear have 3 surgeries. I performed the last one 4 years ago. I found cholesteatoma, canal wall and mastoidectomy, and eustachian tooth dysfunctionalization. Now the dry ear is the ear is dry, but have a hearing loss before the last surgery. The left ear have also 3 surgeries. Second surgery 3 years ago, they found cholesteatoma. They performed a canal and mastoidectomy, eustachian tooth dysfunctionalization, but the patient is still with a wet ear. So I did the first surgery, a cavity revision. I closed the eustachian tooth, but the cavity is still wet. I did this is a single side ear, and I have done multiple topic and systemic antibiotics, and it's still wet, even without the use of a hearing aid.
So I'd be curious your approach to probably both of these years and how you think about addressing both of these, probably linking into Dr. Backus's provocative question a few minutes ago. How you approach
We
that.
have also a CT scan and a videos.
Yep.
We want to show you.
Absolutely. Can we show the videos? It's an otoendoscopy of each ear.
That is the right ear, and you can see down wall mastoidectomy is dry. And that one is the left. Is a good myatoplasty. Is as you can see in the CT scan, the posterior wall is down, but the cavity is still wet. You can see all the time this kind of tissue and a drain of the ear, even without the hearing aid.
So do you want to talk through your thought process on the draining ear and how you think about treating each of these ears?
I have a different question. My first question for my colleagues is, I think the best solution for the patient in the left ear is to put a bone conduction system. But what they do with the wet ear? They leave it just wet, or they will perform an other revision surgery, or they will perform a blind side closure, even if it's a single side ear.
Feel free to just take yourself off mute and jump in. Anyone?
Can I ask you a question regarding this case? Have you already, because the last surgery, there was no cholesteatoma visible anymore, so it's clear for cholesteatoma?
No, the last surgery, it wasn't a cholesteatoma. I just found an open stacking tooth and a lot of tissue in the cavity. So I cleaned the cavity, closed properly the stacking tooth, but it's still wet.
Yeah, so the last surgery was 3 years ago. You found cholesteatoma, you have an open cavity, canal down, so you can see that there is no cholesteatoma recurring in the outpatient clinic, but it's still remaining granulous wet tissue. Is that correct?
Yeah, that's correct.
And have you considered, open question, corticosteroids, nasal drops like Flixonase, I'm not sure how you call it in English, in the ear?
I also put boric acid. I have put this kind of steroids, but all of the drops I put have steroids. So, and I have done, I have put in the patient a treatment with drops like 1 month and it's still wet.
Okay, so I was just wondering, because sometimes you see that like the nasal polyps, you put the drops there, then it goes away, and the granulation tissue in a cavity which is looking that wet, that might be something to, but if you already tried that, of course, then there may be some other panelists with some very bright suggestions.
So if it wasn't her only hearing ear, of course, I would do a subtotal petrosectomy, close the ear canal, eliminate all the mastoid cells. That would be good for her. Discharging, probably dizziness if she has only in that open cavity, but being her only hearing ear, I would like to know how disturbing it is for her, this discharging, if her hearing is restored with a bone conduction implant. I don't think there's much more to do in this case, but of course there are very good panelists that maybe disagree with this option.
Yeah, the problem is that she's complaining about the wet ear.
Dr. Leonard, you had your hand up.
I think she has 2 ears, and the right ear is deaf. What I see from the audiogram. we would go for subtotal petrosectomy, actually on both ears. First on the right ear, and then so give her kind of a closed cavity, and then go for a cochlear implant on the right ear. So if that works, then she has basically also some backup if something would happen with the left ear. On the left ear, you can go for a bone conduction device. I think there is no good chance for hearing improvement with conventional tympanoplasty. And for the wet ear on the left side, we would go for subtotal petrosectomy. So one can discuss it with the patient what to do first, but she definitely would have to undergo several surgeries in order to get an optimum solution for her hearing situation. So,
anyone else have any thoughts?
Yeah, I would think what she urgently needs is obviously hearing restoration, and the left ear with 100% speech recognition is obviously the best ear to focus on. And yes, a bone conduction, a bone anchored hearing device is the best option for this situation. It doesn't seem like surgical restoration has a high chance of success because she's already had 3 surgeries. And even when you look at the ear, you sort of get the feeling that the TM is maybe a little bit retracted. Now, we don't know about the ossicular status, but the very fact that the patient has had 3 operations is a bad thing. The very fact that the patient has bilateral cholesteatoma also indicates to you that eustachian tube function is not likely to be too good. And it seems pointless to go down the road of hearing restoration in this setting. So yes, a bone conduction hearing device and a bone anchored hearing device on the left ear is the best option for hearing restoration. For the discharging ear, depends on how the patient wants it. And as has been said by Dr. Hall and many others, is that a trial of medical therapy seems justified, but if it doesn't work, yes, surgical therapy.
The patient is female, 19 years old. She's a student. She had bilateral ear discharge since childhood and semi-yellow ear discharge last 3 months. Suffering from repetitive ear infection since 6 years old. Recurring antibiotic treatments, local treatment for the last month with 4% boric acid, increasing hearing loss lately. In September 2020, she had left canal wall down tympanoplasty. Now clean ear, but no hearing improvement. So we have discharging ear in the left side, diseased ear, and operated ear in the right side. What you will do?
Why don't we put up the poll question, see what the audience would do, and then we can have that discussion.
I think all of them right. But what we do, I can say that we operate the right ear for reconstructive material surgery for the recurrent ear infection, but at the same time, we put a bone anchored hearing aid to the left side, previous operation side. Why we do that? As a surgeon who did the previous surgery, I know that the left ear don't respond knee osteoplasty better. There is huge infected cells in the mastoid, and we cleaned all of them. Even we do canal wall down tympanoplasty, our graft stick the middle ear mucosa and eustachian tube very highly. Now there is a clean ear in the left side. So going to osteoplasty in the second stage in this ear will not work, I believe that. So we put a BAHA in the previous ear surgery, and did surgery for the right ear for infection, also for hearing at the same stage.
Gerard, you made an interesting comment there that you did the earlier surgery, and so you
Yeah.
had a low level of confidence it was going to get any better with revision surgery. I'd be curious from everyone else how you think differently if you've done the prior operation to move on to a bone conduction aid versus if it comes from anyone else, the feeling of, well, I can fix it, so I should give it a shot. Does it change your algorithm? Should it change your algorithm? And have you evolved in that over the years? I would just be curious from anyone how you approach that.
I don't
Dr.
know,
Ray, I saw
Brian.
you laugh. Yeah.
So,
ahead, Doug.
so just, I don't know if it changes so much my management, but it would certainly change how I evaluate that patient preoperatively. I'm not a big user of CT scans preoperatively for cases unless I have concerns about them. I typically will CT scan somebody who comes in who's been operated elsewhere. So particularly if I don't have an operative summary, I also find that the operative summaries oftentimes don't reflect what I see when I open the ear. So I think it certainly affects how I evaluate the patient. And I really lay it out as a decision to the patient. Would you like an opportunity for a reconstruction? Because no matter how you frame it, wearing a device is a hassle, whether it's a hearing aid, whether it's a BAHA, whatever it is. And I let them make the decision. But I certainly have moved the osseointegrated technology up higher. And what I do include in my conversation is if, we look at chronic ear disease as managing the infection in one column and managing hearing in the other column. And the best hearing result you're going to get is with an osseointegrated device. So I can do my best ossiculoplasty and I'm going to come up short of that device because you still get a small amount of boost in the sensory neural levels, but in a lot of patients, even with something like a BAHA 5.
How often do you think, for anybody here, excuse me, when you're doing a revision OCR, whether it's your revision or somebody else's revision, are you happy with the hearing outcomes?
For me or?
Sure, yeah, for you, when you're operating a revision OCR.
Actually, when I did a revision surgery for hearing, if the previous surgery is tympanoplasty or simple mastoidectomy, the results are favorable, acceptable. But if the first surgery is canal wall down, even he or she had type 3, type 4 ossiculoplasty before, the results are not good in my hands, I think. So if the patient have canal wall down surgery in the first stage, I am not going to ossiculoplasty these patients. I prefer to bone anchored hearing aids or behind the hearing aids if he or she wants before.
Dr. Lennox, get your hand up.
Yeah, I think we have to look on the threshold, the BC threshold, and even with a perfect surgery with closing airborne gap, still you have a 30 dB loss, which means that probably there is a need for amplification. So I think with the given situation, even with some improvement with tympanoplasty, she still would need this amplification. So to go for a bone anchored device, that's one thing, but that does not exclude also to do the tympanoplasty to improve the hearing. The alternative would be if you can basically reduce the airborne gap and the ear is dry, then probably you also could use a conventional hearing aid. So I mean, there is something you also can discuss if that can be achieved, and I think one should be open for both options. Our experience in the last years is that more and more patients vote for bone anchored devices, especially the transcutaneous solutions, because it gives them a very high chance of hearing improvement. So, and you have no problems with the ear canal with conventional hearing aids you might have with radical, with canal wall down. So I think more and more patients opt for that.
If you had a patient like this, same audiogram, but it had multiple operations on both of their ears, would you be looking at a bilateral simultaneous
Yeah.
solution, or would you stage them?
Yeah, we do it. We do it. We would do it also bilateral, simultaneous, because the ears are very, very similar, and so they would have the bilateral hearing then again. No? When you do it on the local, I mean, there is no reason to go for general anesthesia if it's an adult patient as we have here. No?
And are you
Brian, in the United States, I think that's a financial concern.
Yep.
There's no question the medical indication. The reality question is the patient's going to get a whopping bill for that in most insurances. So I'd stage it.
Okay. Anyone else have any thoughts on that, whether financial or otherwise?
We are state funded broadly in the UK, and we do exactly that, simultaneous bilateral, preferably local, and they're fine. They're delighted. The other thing is, if you do sequential, like stapes, often the wow effect of the second surgery is much lower.
Yep, that's true. And both of you mentioned local. Are you, for your adult patients, are you doing the majority of these now under local?
Mixed.
How do you decide who gets general, who gets local?
I just talk to them, and they choose essentially. Some say, "Oh, I don't want anything to do with being awake," and then it becomes a problem. But if you say recovery, there's no recovery issues, etc., then most patients are convinced.
We do general anesthesia.
Anyone else?
We do local anesthesia in all of our adult patients with sedation.
For both transcutaneous and percutaneous?
Yes, for both.
Okay.
It's interesting, Brian, in our experience, we've seen a significant increase in the age of patients undergoing cochlear implantation. And we've started doing more of them under local, and it's shocking how well they do. I would have never believed it. Don't operate on me under local with that big an operation, but
me neither. Yeah.
They do very, very well. And I think, as Xavier just pointed out, it's not an all or nothing. You can give them what we call the Michael Jackson anesthesia, hit them with a little propofol at the critical points of the operation so they fall asleep, and the airway is self-managed, but the majority of the anesthesia is local. And I think key to that is that occipital block, in addition to the regular injection of the area.
Yeah, it's a 48-year-old gentleman who had his first surgery in moved countries. So he had his previous surgeries 6 years prior to the second operation, which we did. He's a lift engineer, often needs to wear a hard hat at work, and is married, has a family with 2 children. Slightly overweight, hypertensive, on medication, has diabetes, which is well controlled, and is an ex-smoker as well. His history was he was suffering from childhood, then ended up having a modified radical canal wall down mastectomy in another country. Then he moved over to the UK, remained symptomatic, wasn't picked up for a while, and then we were consulted, and at that time he had a huge recurrence, so we ended up clearing the mastoid and do a blind sac closure with abdominal fat. The trouble was he had a dip in his right ear as well, which was a dry, healthy ear, mostly through leisure, he says. Now, he's tried cross-aids, he's tried the soft band, which isn't very fetching for him. That's his words. And then he's also tried the other elements in the portfolio, which is the sound arc, which he doesn't like particularly. But they work very well with his hard hat. Now, he's open to suggestions for surgery. So I thought we'd see what the poll says, and then we can decide.
Yes, I checked.
I'm not sure we have a poll for this one, but I was curious, panelists, what you think?
Brian, it's Rafael, and I also see the images that Jadid showed us. It's in the last slides, and I see the grease in the cavity. And for this kind of patient, I will perform a cochlear implant in a single side lens.
How many other people would do a cochlear implant on that ear?
Yeah, I would go for a cochlear implant in the left ear.
How would you stage it? How much time between the closure and the implant?
So it depends on what you find in the first surgery, but sometimes we don't even stage it. We can do subtotal petrosectomy and cochlear implant in the same surgery, but it depends what your findings are. What we wouldn't put in that cavity if there was an infection during the subtotal petrosectomy is fat. We would go for a temporalis muscle flap instead of fat if there was infection in the ear.
So he's
And
1 year
stage-
post-op,
sorry.
and he's recurrence-free on DWI, T2-weighted non-EPI MR.
Mhm.
Would others stage or single stage if
We-
there was no
I
infection at
would
the time of
like
the
to perform in 2 times, in 2 stages, because it's a cholesteatoma. Probably there is biofilms in the cavity, and I would like to put my cochlear implant there. There's a probability to have a biofilm 6 or 8 months after the surgery. So I will perform first the line side closure, and then 6 months after the surgery, do a cochlear implant. Also, because for the insurance here in our country, it's difficult to perform the first surgery for the cholesteatoma and also require a cochlear implant for the same time.
Would anyone favor a bone conduction aid on that side over a cochlear implant?
I think it will be better to use bone conduction hearing aid because there's a probability that the recurrence of infection or recurrence of cholesteatoma, and in that ear, there will be always curious about the new cholesteatoma formation or infection with the cochlear implant. It may be more secure using BAHA in that side.
And how do you think about a percutaneous versus a transcutaneous on a radical mastoid with a blind sac closure that you may have to surveil with?
Actually, transcutaneous will work better in that ear, but most of the patients don't like like being Frankenstein. So transcutaneous one, maybe we will use transcutaneous one in that patient.
I have done that.
We have to explain the patient all possibilities, and we have to encourage him to decide to choose which one.
Rafael, you were talking?
Yes, I have done that percutaneous system since, I don't know, 4 or 5 years ago in our country. I think because probably we are in the tropic zone, the patient have so many problems with the skin, so they don't have, and we don't have this kind of implant. So we do transcutaneous in most of the cases. And now with the new systems, the result of the hearing is much better than before. So we do transcutaneous, and if you want to do MRI, you can do the sequence that is a different name, but it's a mass that suppression of the I don't know how to say in English. It's a sequence special for suppression of this kind of implant, and you can see a beautiful image.
Yep. Great.
So Jaideep, can I ask you a question here about the right ear? I mean, is there any ear discharge in the right ear? Is this also chronic suppurative otitis media in the right ear?
No, the right ear is absolutely dry and well. He's just lost hearing through leisure. That's his take on that. So there's no anatomical abnormality looking into otoscopically.
And I mean, we have tried a hearing aid and it hasn't worked. Of course, it seems difficult because it's a fairly steep high frequency loss, but we have tried a conventional hearing aid and that's not satisfying?
He's not very keen to use hearing aid on the other side, given his experience. So he just wants a reasonable binaural hearing to be safe at work. So that as a lift engineer, his employers would like him to have binaural hearing. So that's where the problem is for him. Otherwise, he might, if he was retired, he was saying he's not bothered at all.
Has he tried a Bicross system?
He's tried, yes, and he's also tried the body-worn bone conductors, soft band and sound arc. So we are not funding, UK doesn't fund unilateral cochlear implants. So my initial hunch was to ask him to move to Germany, to Hanover and contact Professor Lenhars, and that would solve his problem right away. Because he's quite mobile. But then we've been in discussions with him about transcutaneous, percutaneous. I'm really torn about transcutaneous because of the shadow on that side. Monitoring would be quite difficult. And yet, if you put a percutaneous one, whilst it will give him a good solution, there's problems with hard hats, feedback, etc.
We actually have our patients wear their hard hats, cowboy hats, baseball hats, when they come in for the day of surgery, and we try to mark them. And some of them actually will have their industrial head equipment altered and then inspected, and they're able to use their device.
Okay, thanks. Yeah.
And they can do some custom strapping for that. We've done that for hard hats, for football helmets, and lacrosse helmets, where they can contact the manufacturers that can change the strapping mechanism around that as well.
And Brian's referring to American football, not God's football.
Right.
Sorry,
All right.
Brian, this is a
Yeah.
good point that I won't do a bone conduction system because now the right ear shows hearing loss. And she's 48 years. Probably the hearing will increase with the years, and the bone conduction won't fix the problem. So I will prefer the cochlear implant in this case.
So this is a short case, but an interesting one. This is a gentleman that came in 2005, came after having a stapedotomy in 2005 on his left ear and had a persistent conductive hearing loss, had a revision stapedotomy, kind of a classic finding of a lot of scar tissue within the middle ear. Prosthesis appeared to be a little too short. And so we redid that on the left side. And then he had a stapedotomy then done on the right side. And you can see mixed loss on the right, left side has a persistent conductive loss after the stapedotomy. And again, this gets to your point, Brian, if I didn't do his first stapedotomy and I did a CT scan, I found no superior canal dehiscence, no third window effect, no large enlarged vestibular aqueduct, nothing that could be accounting for loss. Even though it's not a classic pattern of loss, I still check for that. And I had a very heart-to-heart type conversation with them about, do you really want to hear well? Because he was very much opposed to even wearing hearing aids. So the scan shows very significant ring signs around both cochlea, indicative of far advanced otosclerosis. On exploration, the round window was open on the left side and on the right side, but it's a mixed loss due to far advanced otosclerosis. So just one more piece of information. We had the otosclerosis study group meeting 2 weeks ago at the American Academy of Otolaryngology, which, by the way, we had live. We were able to drink wine together and share stories and cases. And 0 of 25 surgeons was used an osseointegrated device on this patient. And I think the concern was there's no evidence to support that with any form of cochlear breakdown that the device would be effective. And I can tell you that we've gotten experience with right about 8 or 9 patients, which is not certainly a series, that shows it's quite effective. We've actually seen boosting of the bone line just with the Baha 5. And we found that to be a very nice option for these patients. So I like to throw it out to the world and get more of a global opinion.
Leonard.
think there's the left ear, I think is the easier one, where we can be sure that the bone conduction threshold is true. And so to go for a bone conduction device probably is a good option there. Now for the right ear, one can question whether the bone conduction threshold is really right, because we have this problem of the bilateral mixed hearing loss, and then to do right audiometry. So would be I would say probably might be poorer. And then of course the question is, what could you do on the right ear? So a conventional hearing aid, yes, it might be so, but still the amount of amplification you need in that patient is quite high. So the question is also coming up whether we could go for a cochlear implant on the right ear, depending on what the patient might get with the conventional hearing aid. So that's what I could comment to that case. The other one is, of course, to try to do stable surgery on the right ear, but you already did it. So, and there was probably not a lot of success with, or not what you expected. And this could be due to the fact that that you already closed the gap and the bone conduction threshold is not correctly measured.
How many people bring a bone conduction option into the initial discussion for otosclerosis when you talk about treatment options? And have you seen a change in uptick for that?
No, I think most people would rather not have any kind of device to manage. If it's a mixed loss, I would be more apt to scan and make that available to them. But I've had very few takers.
Dr. Ray, you had raised your hand there. You're offering that?
Yeah, we routinely offer for any stapy surgery. We offer do nothing hearing aid, bone conduction devices, or exploratory tympanotomy with or without stapedectomy. Invariably, most patients prefer to have the stapedectomy as a choice, but you need to discuss risks, benefits as well. And some nowadays, being more informed and being more internet savvy, then want to go for transcutaneous devices. If when you compare stapedectomy with percutaneous devices, the uptake is much lower because of looks. But with transcutaneous, with no risk of to the middle ear or hearing and the connectivity, there is an uptake now.
Yeah, Brian, I did a revision of the rehabilitation for the patient with mixed hearing aid a few months ago, and I couldn't find more than 10 papers talking about that. The truth is, when you have a gap higher than 30 decibel, probably the patient go better with a bone conduction system. So we do tests in all of these cases, and the test is with a hearing aid and then with a bone conduction system, and the patient say which one prefer.
So you see here, she was suffering from conductive hearing loss, 50-year-old female, has a daughter, no general health issues, works in a warehouse. And so she had, ear surgery due to cholesteatoma 2 years ago, then a recurrent cholesteatoma 1 year ago, and there was done revision of tympanoplasty type 3 and mastectomy, and she still has, I think, severe mixed hearing loss on her right ear. Left ear is quite okay, still not perfect, but she basically is asking for help on the right ear.
You want to do the poll now? Asking how people might treat this. All right. We can show the results, please. And there's probably some, Dr. Leonard, when you talk about this, there's probably some interesting thought process you'd have about what does reconstructive surgery mean for this patient? What would you actually do?
Yeah,
On this
what we did is we just gave her an OCR on the right side, and so she's very happy with that. So because she was asking for kind of hearing, you see here just her situation, the CT scan pre-op with this status after 3 times surgery. Basically, the aeration of the middle ear is not very good, and we put in the TORP. There was no real improvement in hearing due to acoustic tube dysfunction. And then you see she has very thick bones, so it was easy to place the screw in and give her this kind of device, and so she's quite happy with that. I will just to see MRI to show that inner ear and all the nerves are okay, nothing specific. There's no inflammation of the inner ear. That's what this MRI scan shows. Okay, that's just the aided threshold. You see she comes up very nicely to 20, 30 dB, and speech recognition is 95%, 65 dB. So that's for her, I mean, the best ever hearing on that ear.
Phenomenal hearing. And have you changed how Dr. Backus was talking about how he has moved the bone conduction up with the newer systems into his treatment algorithm. Has it changed now with the newer technology when you offer that as a potential solution?
I think when you see when you have no good chance for hearing improvement in those ears, I mean, you have done it 1, 2 times, 3 times. It's not a cholesteatoma anymore, but it's just the situation of the middle ear. No aeration or so. I think we have changed it, and we more and more go now to bone conduction devices, because that's a very safe and also let's say high reliable in terms of hearing improvement option.
You can't get much better hearing than that. Yeah, Dr. Rick, you had your hand up.
Yeah, I'd echo that. The new Osseous device has so much headroom, which is brilliant. Even if there's a progression of hearing loss or the cochlear goes somewhat, there's so much headroom. Just a quick question for Thomas, whilst we've got him on the panel. For the Osseous, do you find that the transducer is protruding, and do you recess it at all?
Well, there is a point whether one should do it or not. I think if you have thick bone, like in this lady, probably is a chance to do that. Still, we have enough thickness for the screw, even if you would recess it. So I think it's of course, a question, especially in patients with thin skin or in children. No? So it protrudes, and I think then if you can recess it like in here, I think it's a good way to do it.